Thanks everyone for coming to another episode of Beyond the Exam Room. And today I can honestly say we're so excited and honored to have Dr. Ryan Armour. As you know, he's an amazing neurologist here in New Braunfels, and everybody knows like he's the greatest. So thank you so much for taking your time out of your busy schedule to visit with us today. So obviously the first question is everyone's mind, and this is the number one question I get all the time, is from my patients is like, how do I know as I get older, like when my cognition declines, how do I know that it's normal due to age versus there's something going on? Maybe I'm starting early Alzheimer's. What would you say?
Oh, so it's kind of a tough and complicated question.
Yes.
The sort of the litmus test or the criteria that I look at for someone to need to seek help or some testing or guidance would be if their daily routine seems to be affected by their memory or cognition, or if people around them come up to them and say, "I'm concerned about your memory." Now, even if those things are happening, you may still be normal for your age,
Okay.
but those are sort of red flags or signs that you should talk to your doctor about getting additional testing or having things looked at.
Yeah, so the three most common things when patients come to me are these three, and I tell them that's not necessarily the case. So number one is I go into a room and I forget why I went into the room to pick up, number one. Number two is like there's a word that I want to say, I know what the meaning is, but I can't get that word quite out, and I call it tip of the tongue kind of phenomena. That's another thing that they do all the time. And the other one is and we all do this, is like I keep forgetting where I left my cell phone. And so I'm always looking for my cell phone in the house. So if patients come to you with those kind of concerns, would you be alarmed or not alarmed, and why?
Typically, I'm not alarmed.
Okay.
If it's just those kind of problems,
Right.
those can be part of the normal aging process, or many other things can cause something like that. It could be medication someone started. It could be they're distracted because they're anxious about something going on in their life. Those things I'm not worried about. I'm more worried about things like I forgot to pay my electric bill, and I forgot to pay my electric bill maybe a couple months, and I got a fine, and they turned it off.
Okay.
Or I keep leaving the stove on, and I didn't remember, and my family members had to turn it off for me. Or I leave the water running and didn't remember to turn it off, and maybe even I damaged the house with a flood because I left the water running. Another big thing is I was driving and I got lost, and it took me a long time to make it home, or I couldn't make it home and I had to call for help. Those are the bigger warning signs when you need to worry. But those little minor things that you mentioned before, those themselves are not red flags that would make me worry for someone.
And then for those who are at home and they're seeing their mom or their dad sometimes repeat themselves, and they're concerned, and they don't really know how to approach them. So are there some things that they can kind of test at home to see like where their parents are at?
That's a tough question.
Yeah.
There are no real recommended like home cognition tests to really screen someone to see if someone is developing some dementia or mild cognitive impairment that I'm aware of.
Okay.
You should, if there's a concern like that, then you should just talk to your doctor.
Yeah, and then I think you and I are both excited about what's happening with the dementia world, because before, when where we grew up, we didn't have a lot of weapons in our quiver, right? And we all pretty much had the standard Aricept and Namenda. Now parents are reading about it. I mean, my patients are reading about some of the newer therapies and from AI, and some of those they call them the plaque busters or those kinds of things that actually cause some of the pathology. So can you talk a little bit about some of the new therapies that are coming out?
Yeah. Well, before I do that, though, I want to talk about the ones you mentioned, the
Yeah.
Aricept and Namenda.
Yeah.
So when those came out decades ago, they were indicated for people who already had dementia, and even so, the medication Memantine or Namenda, that was only indicated for moderate to severe dementia. So doctors were waiting until people had moderate or severe dementia before they were starting these medicines.
Right.
Now we know the whole idea with these medicines is to prevent memory loss from worsening. And so the earlier you start it, the better. So now that we've been identifying people earlier with memory problems. We have better testing to identify if we're seeing the beginning signs of Alzheimer's, and we start those medications earlier, we get better results. However, we also have newer amyloid plaque basically destroying medications. These are intravenous medications that are available. Now, not everyone's going to be available for them. There are real strict criteria for who they will help and who they will not. And so that does require extensive testing and evaluation by your doctors to figure that out. They're not effective if you start them too early, but they're also not effective if you start them too late in the course of memory loss or dementia. They're only used for Alzheimer's dementia, and they're not useful in other kinds. So we want to clarify the word dementia means memory loss due to some medical condition, but that can be a lot of things. You can have dementia from a head injury, dementia from a stroke, dementia from other neurological causes. But Alzheimer's dementia specifically is due to the buildup of these plaques and proteins in the brain, and these newer medicines are only useful to try to clean out those plaques and proteins that cause Alzheimer's dementia.
So what I'm hearing you're saying is that we have to identify first that they are indeed Alzheimer's, and then there's a tight window that you can use these amyloid plaque mitigation infusions. Is that correct?
That's right.
Okay, so in the past, there was a lot of confusion because, when I grew up, only way they told you that you can diagnose Alzheimer's was post-mortem. Remember, you had to have a biopsy, brain biopsy and everything. Now, obviously, there's a lot of tools now, right? They have blood tests and other ways. So in your assessment, what is the best way for you to diagnose patients that you conclusively feel like they have Alzheimer's?
The two biggest tools that we have in terms of diagnostic testing, we have the blood tests where we can check the phosphorylated tau and protein levels.
Right.
And there you can also check the beta amyloid levels and calculate some ratios. And by that, those are pretty accurate in determining someone who has Alzheimer's. Not 100% accurate, but pretty accurate. The big breakthrough was about 2 years ago. We got a brain scan for that we can actually visually see the amyloid plaque building up in the brain. It's called an amyvid PET scan. And we're using that quite frequently for our patients now to confirm Alzheimer's and to determine if they're a candidate for these newer intravenous plaque busting medications.
So I know that every imaging centers carry that right now. What's the closest one to our area right now?
It's pretty limited. We're sending most of our patients to the Baptist M&S Center on Wurzbach Parkway in San Antonio.
Okay.
That's been the most reliable and closest location for us.
Okay. So, to me, this is an amazing, amazing breakthrough. First of all, I grew up in an era where we basically diagnosed Alzheimer's pretty much clinically and from history and physical. And then, there was some genetic testing before, but now we have some really good blood tests. And then, of course, the confirmative imaging test, which is really, really nice. So that we don't have to kind of wonder. And so from your assessment, like if I'm a patient and I'm really concerned that like my mom has Alzheimer's, right? What's the first thing that I should do?
Well, first thing you should do is talk to your primary care doctor.
Okay.
And there's some testing that can be done by your primary care doctor to screen. Maybe there's something else going on.
Yeah.
And the initial part of the workup can be done by your primary care doctor. Right. But part of that workup may be a referral to a neurologist.
Right.
And that can be initiated at that time. There's not many of us around, and there is a long wait.
Exactly.
To get
That's the
into
issue.
this.
Yeah.
So
you're a very limited resource, right? That's the issue that I was trying. So if there's a way like the primary care physician can order the blood test maybe, and then can they also order the imaging, or do they only want neurologists doing those?
No, the primary care doctors can and some are ordering the imaging.
Okay.
You usually will need an MRI scan or a CAT scan first because that's more useful to rule out other causes, other kinds of dementia other than Alzheimer's may show up on those tests.
Right.
And it's necessary part of the workup. And then there's some blood tests to check for other things such as vitamin deficiencies, thyroid deficiencies. That can mimic Alzheimer's disease. It's very important to look at that. So that's done initially by your primary care doctor. Sometimes it's not done, and then I will order those tests, but we can get ahead of the game by seeing your primary care doctor and getting those tests and the ball rolling there.
Especially since the window is really tight, right? You said it can't be too early and it can't be too late, right? Before you can start using the infusion. So from your experience, how effective have the infusions been?
So we haven't had hundreds of patients on it,
Right.
but the patients that we've had, we've seen them be effective. Now, to be clear, these medications are not going to improve memory, and I tell all my patients, we're never going to make your memory like it was when you were 20 years old. That's just not going to happen. The goal is to maintain the memory that they have left, or to slow down the worsening of the memory that's going to occur with Alzheimer's disease. What we've seen in the patients where we've started these medications is before we started the medicine, they were on a downhill slide fast with the memory. And we start the medications and it stabilizes. So the memory may still get a little worse, but not nearly as fast as it was before starting the medication.
So you've seen the slope of the decline flattening out a lot then?
Absolutely.
Okay. So at which point would you say like Namenda and Aricept is no longer effective and patients should not be taking them?
They're still effective even in moderate cases of Alzheimer's, and Namenda, there's an argument that it could be still effective in severe cases. But once someone has reached the point where they are totally dependent on all their activities of daily living and can't really get themselves dressed anymore, can't carry on a conversation, can't really remember their family anymore, and just require full assistance for everything, the risks of causing side effects with those medications is going to outweigh the benefit, and then we will stop them.
Yeah, when I used to do house call at memory care, I noticed that the lockdown units, and of course those are patients that are very, very severe, that they have to go to memory care. And it's invariably what I saw, they were all on Namenda, they were all on Aricept, and then they were even on like cholesterol medications and all these other things, and you kind of scratch your head like, why would that happen? It doesn't make sense. But I think part of it is just people are just afraid to take those medications off. And so I agree with you. Unless you see a significant benefit from the medication, I think it'd be better if they don't take it, right?
Yeah, so when someone's reached that point in their dementia, we really should be more focused on quality of life. And a lot of those medications really, we know, can reduce the quality of life. They can cause fatigue, muscle aches, diarrhea, slow heart rate, even passing out, lightheadedness. So we really want to review the medications and say, our litmus test is, do we think this medication could be doing more harm than good for the patient? And if we think it could be doing more harm, let's cut it out.
Yeah, that's a good review. So, I'm like you, I'm a student of AI and I'm always searching it. And so some of the things that are coming that I see is pretty exciting. And so what are your thoughts about that we're going to have significant improvement in Alzheimer's in the next 5 years?
Well, we're hoping that they come out with medications that, number one, say are not so cumbersome to give, and they're already working on that, and that's getting close.
Right.
So, for example, right now, the medications have to be given intravenously.
Yeah.
You have to go to an infusion center. A nurse has to start an IV, and they're moving toward home injections for these medications.
But there's bleeding complications, if I remember correctly, right? Some with these injections, is that correct?
So there is. So with the injections we have now, you have to monitor very closely with MRIs almost on a monthly basis to make sure people are not having bleeding, brain swelling, and to be put at risk for seizures and other neurological conditions. So we're hoping that with clinical trials, AI breakthroughs, and so on, that they can come out with safer medications that won't have that side effect risk and not need so close monitoring as well.
Yeah, and then I was reading some studies and they're trying to understand these cells that create these amyloid plaques. And they're trying to figure out how they can actually work at the cellular level so they don't start producing these plaques. What do you think of what do you think the odds of something like that coming out in the next 5 years?
I think that line of research is in its infancy, and I think we're at least 5 years away from coming out with a breakthrough and a medication. Once they identify a target that a medication could work on, then they'll have to develop medications that will, if you will, stick to those targets or block those targets. And that's going to be done in the lab in dishes.
Right.
And then once you find some potential candidates there, they have to do animal studies. And then after that, then they do human studies for safety.
Right.
Then after that, then they have to do human studies to see if they're effective or not. And then still test the safety. And if you can imagine how all this goes, that takes years and years and years.
Right.
So I'm hopeful, but I'm a little doubtful that we'll have a major breakthrough in something like that in the next 5 years.
Yeah. So for you, the question I ask for you too is because your resource, your capacity is so limited. I think it would be very helpful for the primary care clinicians can do a lot of the workup before they send them to you. Would you agree?
Absolutely.
Yeah.
Yeah. The just the cognitive testing, the
Right.
questions we ask in the office, a lot of that can be done by a primary care doctor. So we have a baseline, we know where someone's at. That alone can tell us at what stage in the process someone is at. A lot of the brain scans, the blood tests can also be initiated by the primary care doctor. And then once all the data is collected, then the patient could come see the neurologist, and the neurologist can do a review of the data and kind of come to some conclusions about what treatment can be done. The oral tablets that we have, the Namenda, Memantine, and donepezil, Aricept, also can be initiated by the primary care doctor, and I love it when that happens because, like I said before, the earlier we initiate treatment, we know the more we have slowed the process.
I agree so much. I mean, we can talk about the subject so much because it's so rampant, and that's one of the most common concerns that my patients have. So I want to thank you again for your time. It's extremely valuable. I hope people can watch this because for your primary care clinicians out here, it would really help if you can do all the workup before we send them to a neurologist so they don't have to delay their treatment. And so I want to thank everyone. All right, have a good day.